Hi and welcome to the 8th episode of the Cannabinoid Journal podcast. My name is Róisín Delaney and I'm today joined by some brilliant guests who will be talking to us about their ideas for advancing the case for medicinal cannabis in the UK. All of our guests today are recently published authors, having put pen to paper for Decalogue, a series of essays commissioned by the Centre for Medicinal Cannabis in recent weeks. Decalogue is a collection of ideas to accelerate patient access and therapeutic understanding of medicinal cannabis. So let's talk to our guests. Let's have a quick chat with them about their individual papers and see how we can drive this conversation forward. Joining us is Pierre Van Gerpen, who is the Managing Director of Grow Group UK and CEO of Grow Pharma. We also have Dr. Ayesha Mian, who is a medical doctor within the NHS, an advisor to the Centre for Medicinal Cannabis. Also joining us is Dr. Parveen Batara, who is the Compliance and Regulatory Advisor to the Centre for Medicinal Cannabis. And we're also really delighted to be joined by Alfredo Pascual, who is a prominent cannabis industry analyst and Vice President of Investment Analysis at Seed Innovations. Thank you all for coming, and all of your titles are very impressive and we got through that bit okay. So we're going to move through to some questions for each of you. But I think one of the great things about Decalogue, having been at the event a couple of weeks ago at Imperial College London, was everyone got to have a real conversation around these ideas. It wasn't a mandate, it wasn't a strict agenda, it was very much a conversational kind of room where we just opened it up to the floor for discussion to talk about these ideas a little bit more. So I'm going to come to Pierre first, if that's okay, to kind of just go through the ideas that you put forward for Decalogue, Pierre. I know you wrote two papers, and you wrote one yourself and you co-authored a second. And I think the second one, the export-led growth potential piece, that really struck a chord with a lot of people who were in attendance at the Great Hall a couple of weeks ago at Imperial College London. So just take us through the kind of, I guess, argument you were putting forward in that piece that you co-wrote, if you can.
Yeah, happy to. Thanks for having me, by the way. Obviously, love to be here. So what did we talk about in that second paper? As we all know, cannabis is a controlled drug and Schedule 2, but for some reason, there is a policy top-up on the regulation. That means that we need to have on a patient need import licenses, but we also cannot export cannabis-based medicines from the UK, which is a bit of a shame, because we can export any other Schedule 2 drugs that we manufacture in the UK, and there is plenty of manufacturing going on. And the European market, as we pointed out in the paper, the European market is forecast to be quite significant, couple of £billion or euros in the next 5-6 years. And it would be a real shame if we missed the opportunity to use UK manufacturing to manufacture cannabis medicines here and export them, and cannot export them to the European market. Even if we would only get, let's say, 10% share of that market, we would probably have a revenue of a couple of $100 million that would add to the UK revenue. And not just that, it would also increase jobs and job opportunities. Because of the expertise, it would probably also help investment coming into UK to do that. And at the moment, we're missing out on that. And that's the case that we're trying to make. Allow us to export, basically treat medical cannabis the same way as we would treat any other Schedule 2 drug, and allow us to export.
What needs to happen? Like, what's the critical first step with every major change within the healthcare system or an approach to a drug? There's always one kind of step that initiates that, the ignition, basically, that kind of pushes it forward. So what needs to happen in the case of medical cannabis that isn't happening?
Very, very good question, and actually a very simple answer, because it's not a law. There is no cannabis is being treated as a Schedule 2 drug, but with an extra policy bit on top of that stops us from exporting. It's just a policy change, and that's something that I would say Home Office need to talk to MHRA. I need to talk to probably. It's probably just export and revenue, and have a conversation about why we're treating cannabis differently than anything else. So it's a policy change which can be made basically over a weekend. Nothing really big needs to happen. People just need to agree that there's an opportunity here, change the policy, and get on with it.
So the idea is there, the will needs to be there, and the drive needs to be there, I suppose, to push it across.
Exactly. Yeah.
I want to bring Parveen in on this, Dr. Parveen Batara, because you, similar to Pierre, you co-wrote one of the papers for Decalogue with Professor Trevor, and it was such a cohesive kind of argument that you put forward that really made a lot of sense in what you said. When you're talking about, you know, the UK as a place for clinical trials to be embraced, a place for data to come from pertaining to this drug that is doing really, really well in places like Germany, Australia, Israel, Portugal, Denmark, on not just manufacturing grounds, but research grounds too. So can you tell us a little bit about, you know, your argument that you put forward in your Decalogue paper, please, Parveen?
Yeah, thank you, Róisín. Thank you very much for having me on. Yes, very good question. And I think I agree with Pierre, as he mentioned, that that we have a great opportunity here with cannabis-based medicines, and we need to prevail that opportunity. And my view is that I'm a mere scientist. I've been working in this industry, especially in the cannabis area, for 12 years, and having developed a medicinal cannabis product, I feel now at this stage that I just really only just now realized that this industry is ultimately still a product of political and public policy. Without that, we are not going to move further. Yes, doesn't matter how good scientists we are, doesn't matter how much intentions we have, innovative ideas we have, we need to make sure that there is public and political will and policy change need to happen for any success, any innovation, any sustainability in this area. So I really feel that the regulatory innovation is necessary in this case to push these boundaries of science using the nature and using the prior experience. And that's really what I have put forward in my paper, because I think in UK, we already have a platform via the orphan drugs route, via the EMSA, via the iLab, which is innovative license success pathway. All these opportunities, MHRA have already there. With a little bit more innovative regulatory innovation in this area, we will be able to have a success in this area. So I think we need to take this opportunity now, otherwise it is going to be too late and in comparison to rest of the countries.
It was really interesting to listen to yourself and Professor Trevor Jones at the Decalogue event a couple of weeks ago. I think you were first up on the schedule to present your ideas. And what was really evident to me listening in on the sidelines was, you know, in this country, we have some of the best universities in the world. We have groundbreaking innovation happening in other sectors, especially in other, you know, sectors within the life sciences umbrella. We have a healthcare system that people genuinely are very passionate and supportive of. But for some reason, when it comes to, you know, medicinal cannabis, we legalized in 2018, but then we didn't really take it in places where the likes of Germany took it. So I want to bring Alfredo in, if I can, Alfredo Pascual, into the conversation. And Alfredo, you touched on this point as well. You presented, you know, kind of some, I guess, comparisons between the German market, which is by far the largest medicinal cannabis market in Europe, and the UK. Similarities, but more differences than anything, because these are two nations which legalized within, you know, months of each other. I think Germany was 2017, the UK was November 2018, but they've both gone down very different paths since then. So can you tell us a little bit about what it's like in Germany, how it's different to the UK, and just go through that from your paper, if you don't mind?
Sure, happy to do that, and thank you for having me here. I guess it may be useful if I first say what motivated me to write what I wrote, and it is the fact that I keep hearing the argument in the UK that that access to medical cannabis in the UK is not more widespread, or the market isn't larger because of the lack of research. And we always keep repeating this mantra that we need more research, and so long as we don't have more research, then the market for medical cannabis will not grow as much as we would like to. And I emphasized during the presentation that I had in London and also in the paper that it's not that I am against research, of course. I mean, yes, we will always need more research, but that fact alone doesn't explain why, as you were correctly saying, Germany and the UK evolved in very different ways after they changed their rules, let's say, in 2017 and 2018, respectively, to allow for a broader access to medical cannabis. And in the paper, what I try to do is to try to find the differences in a way between these two countries and explain then why Germany grew in a way that the UK hasn't been able to so far, at least. And when I was doing that exercise, I identified what I ended up calling 7 pillars of the German market, because my first thought when I was writing the paper is, okay, it's the public health reimbursement, which is what everyone talks about when speaking about Germany. In Germany, medical cannabis is covered by the health insurance, so obviously it's going to be a larger market than in the UK. That, of course, it's a huge part of the reason, and it is certainly very important. But I would argue it's not the only reason, because we also have other markets in other countries where there's no widespread coverage from the public health system for medical cannabis, yet that they have also grown quite rapidly in the past couple of years, more so than in the UK. And here I can think of the examples of Israel and Australia, both markets with the number of patients that is probably around or approaching 100,000, and where there's no widespread public health coverage of medical cannabis. So that when I was writing the paper, I thought, okay, I cannot say it simply because public health insurance coverage of medical cannabis, there must be something else. And that's how I started finding the other 6 pillars to complete the 7 that I identified in the paper. And quickly going through them now, the second one that I wrote is, I think, one that is very important in the UK context. And it is that in Germany, any doctor other than dentists and veterinarians can prescribe medical cannabis, which is not the case in the UK. As I understand, it's only specialists that can at least initially prescribe, or at least it's much more restrictive in that regard than Germany. And it is complicated everywhere in the world, I would say, to find a doctor willing to prescribe cannabis. But if you shrink the doctors' populations that could be that could legally do so, then it's going to be even harder, right? So you have a smaller doctors' population in the UK, from which you can find doctors willing to prescribe cannabis. That makes it more complicated. Then I would say that another important pillar, and number 3 that I have in the paper, is the history of medical cannabis in Germany preceding the 2017 reform. And I would say that here, arguably, maybe the UK needs to be a little bit more patient, because in the UK, medical cannabis, at least when it comes to what you in the UK called unlicensed medical cannabis, its history started basically in 2018. Before that, there was basically nothing meaningful, I would say. And in the case of Germany, it is true, and it's often said that Germany legalized medical cannabis in 2017, but it is also true that there was something before 2017. Some patients, through a very complex process, could have a special authorization to have access to flower. And actually, there were about 1,000 patients accessing to flower before the change of the law in 2017 in Germany, which means that there were a bunch of doctors prescribing these products, which means that Germany didn't start from 0 in 2017. It started from something small, but still something. So that's another difference, I would say, I argue with the UK. And then there are other, perhaps, smaller or other pillars that play a smaller role, but that I also thought was important to mention. And it is the role that pharmacies play in Germany, which is quite important, because in Germany, to dispense what you in the UK would call unlicensed medical cannabis products, these are in Germany categorized as magistral preparations or products for compounding at the pharmacy level, which means there's a step that the pharmacy needs to do with the product before dispensing it. And that means that there's a that pharmacies, I would argue, play a more important role in Germany than what they do in the UK, even when it comes to regulations, even when it comes to securing a widespread geographical access. So yeah, that's another point to consider. Another one, the fifth one, is in-country cultivation. That's in Germany quite important because it was, I would say, a central part of the law reform in 2017. We all probably know that it has been delayed over and over again, but now we have the first harvests. And yes, arguably, these first harvests are still quite small when it comes to the total demand in Germany. But I would argue that in-country cultivation played a role putting some price pressure, and also, well, of course, bringing the economic benefits of cultivating in the country. And also with the price pressure, it also helped patients paying out of pocket in Germany, which are quite a few. I also mentioned the magistral preparations thing that is important in Germany. And I would argue that here a similarity with the UK is that access to flower is possible in both countries. That's not always the case. There are a few European countries where there's access to medical cannabis, but not to flower. Here, it's kudos both to Germany and the UK. And another one that I think it's kudos to both countries is that there's no limited list of medical conditions for which medical cannabis can be prescribed. As it is the case in certain US states, I think also Portugal has some sort of list, and doctors can only prescribe if it is for one of these options that are listed there. That's not the case in Germany and the UK.
Thank you for running us through all of that. It really kind of paints a picture of kind of, it's almost like a SWOT analysis of the situation in one breath. And a couple of things that stand out to me from your paper, Alfredo. I want to bring Dr. Ayesha Mian in on this from her kind of role as a doctor operating within NHS England. And that is that, the idea of GPs being able to prescribe and the idea of pharmacies having a more active role. Ayesha, what do you say to that in terms of, the future of the NHS long-term plan? Do you think in the years to come that it's an opportunity, an actual opportunity for doctors to kind of, do more good and actually, support GPs in that sense as well?
Yeah, so we have to understand that obviously the impact of COVID is an accelerating factor, but even before that, the NHS has been struggling for quite some time. And overall, a lot of indicators of health, like mortality and morbidity, overall, they have also been declining in the last 10 years. I referenced a lot Sir Michael Marmot's report, Build Back Better, from the Institute of Health Equity. And he's just been saying essentially since 2010-ish, we've had sort of hit after hit after hit, and a lot of policy decisions that have made inequalities a lot worse. And there's many, many different factors that have contributed to the situation in the NHS at the moment, where really, it's really difficult to even deliver basic services in some places. So this medical cannabis thing, in terms of getting doctors or healthcare professionals or pharmacists involved, there has to be some incentive from their point of view, and it has to be presented as well to them in a view that they're going to be more amenable to, because currently they're coming from a space where any education or information that they might have around this is already negatively biased against any kind of beneficial effect. And that obviously has a big influence from media and public policy and any of the millions of different strategies and things that we have that might influence access to medical cannabis. So I mean, I can say anytime I try and talk about it or I try and have a conversation, you go back to really some very basic things so it's just THC and CBD, and THC is bad and CBD is good, and is it just about people getting high? And very simple things, because people medical healthcare professionals here don't know. And in terms of trying to educate them, I know there's a lot of efforts from the industry that, to try and make educational materials or events or whatever else, but doctors need standards, we need protocols, we follow guidelines, we need some kind of authorized development of this is something that I've said in my essay. We need to have like a standardized professionally accredited curriculum for this. I know that some people are prescribing based off 1-2 days, a couple of days worth of going to a few webinars, and that if you understand the endocannabinoid system even slightly, I just think that how can you really sell that once you start to try and explain to healthcare professionals the complexity of the system? There's so much for them to grasp. A lot of it is beyond their traditional understanding of healthcare, and doing it in just a couple of webinars, and on top of that, they're probably quite hesitant to even engage in things like that, because they're like, what's the point? Can I even prescribe at the end of this? Because only a few people can prescribe. There's so many gaps in the framework of the industry and how it should be shaped, really. And the question is, where is this leadership going to come from? So I do very much so agree with a lot of the things that people have said. Ultimately, it all comes down to public and political will. How can we change this? How can we destigmatize what is there so we can actually start to develop some of these frameworks that we need to have operate in a much safer and I guess a much more ethically and sustainable manner around medical cannabis? There should be a curriculum. GP should be involved in this. If anything, it could be a GP special interest. I mean, GPs have to know everything about everything to an extent, or at least at the very least, what they need to know is how to spot what we call red flags. So that's key signs and symptoms that could indicate a more sinister pathology. And that's what will then be referred into a tertiary healthcare center, or basically to a specialist. Even for GPs, you would need to have a fairly extensive course and training on the endocannabinoid system, on the products, how to see patients, how to treat patients. And it wouldn't just be, the nature of it means it's not just, necessarily medical cannabis in and of itself. You have to understand broader understanding. You have to have a broader understanding of health, which includes things like, are people getting the right amount of sleep? Do they have access to mental health services? Do they have access to good food? All of these other things that shape the environment that they live in, and in turn the health that they have. It's actually a very complicated thing that I think when it comes to healthcare professionals, they would need a bit of a top-down kind of approach, which makes them feel a little less afraid of even engaging with this subject. And that approach should be evidence-based, basically.
You're kind of talking about there, looking at and having respect towards the social determinants of health, which you wrote about within your essay, looking at the other lifestyle factors that these patients have and making, decisions based on those, as well as, signs and symptoms that they may be showing. From your kind of, I suppose, perspective as someone who's working within the NHS at the moment, what is the attitude towards medical cannabis? If you can give a general overview, I don't know how if you've had conversations with colleagues, or what's the...
There is almost no positive feedback I get, and the positive feedback I might get is in those spaces, specifically if you're going to an event that's specifically around it, and it might get some hint of people, but if you listen to the questions, if you listen to the audience members, what they're thinking and what they're saying, they're still very, very apprehensive about this. They really are not, and they're afraid, because everything from all of our institutions, the Royal Colleges, anywhere that we look to in terms of how we practice and the standards within which we're supposed to practice, it does not have there's no favorable view towards medical cannabis. So there's a lot of apprehension, I think, amongst some of the either you have very experienced, practically retired certain specialists who have probably had a bit more of a colorful career. So they've had a bit more of a diverse range of experiences, which makes them start to understand this more of a holistic approach towards healthcare. And they might be more amenable, but then they're essentially retired. So what are you going to get from them? It's limited. And then the younger ones that are going through training, they still kind of don't really know. They're still apprehensive. And the ones that are a bit more amenable, they're still afraid because they're too junior. And if they're not going to have senior support, or if they're not going to have, if they have nothing to back them in terms of trying to speak out or learn more about that, there's no incentive anywhere for them to want to do that. There's enough of a struggle in terms of getting through training and the core training requirements. And then on top of that, you've got medical cannabis. And then on top of that, medical cannabis is seen so negatively. So where is the incentive really? It's not an environment that really promotes like wanting to learn about this, even if there is a small attitude in certain areas of people wanting to do it. Because then even if they learn about it, then what are they going to do?
Can I ask a question, Róisín and Ayesha? So if you compare that to, take Germany or Australia, where did they start? I mean, they were a year ahead of us. So how come in Germany we have 2,500, 3,000 doctors who are prescribing medical cannabis, and in the UK we have, what, give or take, 60, 70, 80? It's not that doctors' mentality is any different there, isn't it? If you want to learn, you can, and get it. Maybe Alfredo has an idea about that. I don't know, but
well, I had a similar question like Pierre, and same thing I wanted to ask Ayesha was that if you are saying that further knowledge, further experience on that will take time, and hence there's not enough time in a junior doctor's life to understand all these things, and it will take time and years to come. But do you think that if there are experts in the area, if they can start working with the expert buddy who is expert in the medicinal cannabis and the junior doctors working with them, would that sort of scheme will work and help? And along with obviously the health insurance, because doctors don't want to take any decision which is going to impact their career, and they want to make a decision which are really safe and secure, so they can't impact on their really hard-earned money. So will that be helpful if knowledge on its own won't be helpful? If there are experts, for example, there are private specialists who are expert in the cannabis area, if they are working together with them, is there some sort of option there which we can use?
So this is something that I'm trying to understand, like what could be the ways forward. So as I was saying, like a standardized curriculum needs to be developed. And I don't think that there should be any problem with private industry that has experience in obviously like development and research and whatever else to have some contribution to a curriculum, because that's valuable knowledge, but knowledge should come from all spaces. I very briefly mentioned knowledge equity. I mean, like there's patients out there that know far more than even industry so-called experts that I've met. They do a very, very extensive amount of research that I still learn a lot from. There's a lot of different types of knowledge all out there, but it all needs to be combined into a standardized curriculum. And then that curriculum, if it's a course, an accredited course, you target it to whatever level. It can be either a special interest. So I think most people that do special interest as a GP basically ends up being a postgraduate certificate or diploma. And then that kind of gives a level playing field. And on top of that, you can build on whatever else it is, because otherwise, I just don't see how you can be a confident prescriber based on what we currently have out there. And it's just too risky. Who's going to take those risks? The few doctors out there that have been, so-called reported to the GMC, and then already people are quite afraid, especially if you're even a doctor of color. Like there are issues against that. There are still inequalities even within the NHS that exist. So who's willing to take these risks? Are you associated with an institution, an academic institution that has very strong I guess, public and political influence, and you can resist the critique and you have this sort of air of credibility. But then what about people from other kinds of institutions? What about people that are trying to learn from like DGHs, district general hospitals, or, you know, it's not, there's quite a lot of factors in this, but I do think ultimately there just needs to be like just a standardized curriculum, something that consolidates all of this knowledge into one place, and then you have an incentivized, you have somewhere that doctors feel safer to go and learn from, and on top of that, then you know it can then become developed into you know, just something that they're willing to learn from and then actually put into practice as well, because they can practice based off that safely.
Can I challenge that a little bit, Ayesha? I mean, when you speak to the doctors, I completely agree with you. I joined pharmaceutical cannabis industry 2 years ago, and the only prescribing doctors were people who were kind of towards the end of their career, very experienced, and started doing this mostly because patients continued asking about it, and they just thought, oh, well, if I want to learn, I need to learn. They learned themselves, started doing it, and got more experience by doing it. When you look at the group of prescribers now, the half of them are significantly younger, and just are starting to driven by patients asking, thinking, oh, I need to get myself into this. I need to learn, and you can find ways to learn. I completely agree with Parveen's comment. We've done a couple of webinars where we have experienced people talk to people who are interested, and having somebody like that as a backdrop or help is also incredibly useful. But there's also this bit about lack of, I don't know, what's the word? You mentioned insurance. So Anthony Ortman, who works in Integra Clinic, he spoke to the GMC and spoke to his insurance company and said, I think I need to inform you that I'm now going to do medical cannabis. What's the impact on my insurance? And they said, well, that's fine. That's £1 more per month. Done. Wow. It's nothing, no more than that. So I think we assume a lot of things, that it's difficult or that we shouldn't or that it's more complicated than it is. But once you actually start doing it, it appears to be a lot easier than it actually is. And then you learn while doing, as long as we provide expert safety nets or helps. And in the clinics, we have MDTs, yes, where every patient comes in, and every second day there is an MDT where every patient is discussed. It's not like somebody just writes prescriptions and off you go. Patients are being discussed. Patients need to do eligibility. It's not that difficult, really. It's just having that. And I can see the point around stigma, and I can see the point around being a little bit inexperienced and cannabis this and cannabis that. But once you're over that, it's actually quite easy to do.
Well, I was thinking, thank you, Pierre, for clarifying the insurance bit, because I was under the impression that most GPs or doctors are scared because of the insurance and risk attached to it. If that's not the case, then we are, as Ayesha is saying, being a junior doctor, she's looking for a standardized module where she can feel comfortable that she is really following the regulations as per se. And I think we have now established, in my view, which I wasn't clear on before, that if we have an expert in the art, the skilled people setting up these things and helping these youngsters in breaking those barriers, I think we have an opportunity there. And I think it will be a good idea to hear from Alfredo from Germany. Is that what Germany did? Is that how they have that many doctors? Or is there something else we are missing here?
Yeah, please, Alfredo, let's bring you back into the conversation and see, what do you think to Parveen's points there, and how Germany has evolved in comparison to the attitudes within the NHS?
So I think the question is centered mostly in terms of the number of doctors prescribing, right?
Yeah.
And how that evolved differently in Germany. Well, I think I already hinted at two things that I think are quite important and that explain at least partially the difference. One is the fact that general practitioners can prescribe in Germany, and as I understand, not, or at least not the first prescription in the UK. So that makes a big difference for many reasons. Obviously, you have more doctors that could potentially prescribe, but also because I would say as I understand, it is easier for a patient to talk about cannabis prescription with the family doctor, general practitioners, than going to a specialist to talk about it. A specialist that doesn't know the patient as well as the family doctor probably, and also that the patient probably doesn't know as well the doctor either in terms of the trust patient doctor, right? So I think this is key. So long as it's only specialists in the UK, you have a huge barrier there, because when a patient is trying, for example, cannabis from the illicit market and knows it's working and then wants to get a legal prescription, the patient needs to, in a way, there ask the specialist, and specialist, oh, wow, that's a big doctor out there. How am I gonna ask this important doctor to prescribe cannabis to me? And I don't wanna say that GPs are not important, but they are more accessible, I would say, when it comes to patients and patients, explaining whatever it may be. So that's a huge thing. And the other one is also something that I mentioned, and it is that Germany didn't start from zero. And this is something that it's hard to change in the UK, because in the UK in 2018, you started almost from zero, I would say. And in the case of Germany in 2017, it's, yes, 1.5 years before, but I insist, Germany didn't start from zero. There were about 1,000 patients that were accessing to flower, meaning that there were a couple of dozen or maybe more doctors that were already prescribing before the change of the law. The change of the law expanded the toolbox of these doctors, and obviously new doctors started to prescribe as well. But I think it helped a lot that Germany didn't start from zero.
Thank you.
I think you make a really good point. I mean, we are probably a bit impatient, isn't it? We see where it is in other countries. You go, yeah, we want the same thing. I completely agree.
Yeah, I mean, and you cannot change that. And the same applies. So I mentioned Australia and Israel, right? As other countries that in the past couple of years saw an impressive growth in the number of patients. But again, they didn't start from zero a couple of years ago. I mean, arguably, Israel has one of the longest medical programs outside North America, at least, if not in the world. And in the case of Australia, I think they started in 2016, if I remember correctly. I'm not that familiar with the Australian market, but certainly even before Germany. Even if in a very small scale. And these two countries saw I would say an explosive growth in the number of patients just in the last 2 years, basically. So yeah, maybe you will see that in the UK in 2024, let's say. And yeah, as Pierre is saying, you just gotta be patient, because when you started in 2018, unless you correct me, I think you started basically from zero there. And talking about unlicensed cannabis, right? And leaving aside licensed medicines.
And the foundations that need to be built upon. And look, we're doing it. We're doing what we need to. We're having conversations. We're coming up with ideas. We're having difficult discussions, trying to figure out where the opportunities lie.
Sure.
Yeah.
Absolutely. Brilliant. Well, thank you all for taking the time out this afternoon to jump on this podcast for the Cannabinoid Journal. Just a reminder to you all and to anyone who is listening, all of the essays for the Decalogue publication can be found at decalogue.info, or you can go to the Centre for Medicinal Cannabis website as well, and all of the details are there. And we do encourage lots of interaction, so if you do want to give us your thoughts on any of the papers, or if you would like to get in touch with any of our speakers or any of our guests on the podcast today, please do so, because it's all about generating constructive ideas that can become a reality in the future. So Pierre, Parveen, Ayesha and Alfredo, thank you very much, and go about your weeks and your weekends and have a great time.
Thank you.
Thank you.
Thank you.
Thanks.
Thank you. Bye-bye.
Thanks everyone.